Chapter 195, Management of Pain by Percutaneous Anesthetic Injections and Neurolysis. Anesthetic techniques are not standalone treatments for pain, but rather an integral component to a comprehensive approach. As the field of pain medicine matures, we continue to advance the role of neuroblockade using local anesthetics and steroids in order to diagnose and treat pain. With the ongoing opioid crisis, there is a call for non-opioid multimodal therapies to treat chronic pain. This chapter reviews goals and methods of anesthetic injection and neurolysis in pain management. We will cover indications and patient selection for common, minimally invasive, interventional procedures, including epidural steroid injections, facet joint procedures, and sympathetic blocks. We will also discuss how anesthetic procedures can be diagnostic for surgical indications or therapeutically delay the need for surgery. Please read the chapter for further details on evidence-based practice and recommendations. Prior to any pain procedure, careful attention to patient selection, technique, and process is critical. Table 195.1 is a guide for approaching diagnostic injections, which provide temporary pain relief and gather data for surgery indications, but should not be viewed as therapy. It is crucial that patients, during consent, understand the relief from pain, if any, will be brief. In diagnostic blocks, local anesthetics are injected near suspected nerve fibers under imaging guidance in conjunction with anatomical knowledge of innervation patterns. Figures 195 and 182, for instance, demonstrates needle placement for a celiac plexus block. The local anesthetic will block sodium channels in the nerve membrane to decrease transmission of sensory motor or sympathetic inflammation. If effective, temporary pain relief will be identified by the patient and recorded in an hourly pain log. If the timing of subjective pain relief correlates with a known pharmacology of the anesthetic injected, the diagnostic block has succeeded in confirming the location of the underlying pain pathology for somatic and sympathetic nerves. In this case, more definitive interventions such as minimally invasive nerve ablations or open surgery can then be planned. In contrast to diagnostic injections, therapeutic injections are based on the phenomenon of prolonged pain relief after local anesthetic injection. Basic science research suggests that such pain relief may result from a combination of altered central nervous system function, altered muscle tone of the affected area, or a change in peripheral nerve physiology or morphology. Corticosteroids are often included in therapeutic injections and can reduce perineural inflammation. When interventional procedures were first introduced, epidural steroid injections were performed using a blind technique. Even in the hands of a skilled and experienced proceduralist, inaccurate needle placement occurred in 25 to 30% of blind injections. The ability to visualize the target allows placement of the introducer needle with fewer trajectory corrections, reducing procedure time and tissue trauma. Injecting low-dose contrast material under fluoroscopy provides opacification of tissue planes. This quickly identifies complications, such as intravascular or intrathecal needle placement, minimizing the respective risk of local anesthetic system toxicity and total spinal or arachnoiditis. Thus, fluoroscopy is now the standard of care for most interventional procedures, especially around neuraxial sites. Ultrasound imaging has improved dramatically over the past few decades and is now the standard of care for guiding placement of regional peripheral nerve blocks. There is also some evidence that ultrasound guidance is useful when performing percutaneous pain procedures. Ultrasonography is radiation-free, easy to use, and provides real-time images to guide needle placement. However, while ultrasonography clearly demonstrates the bony structures, soft tissue such as nerves can be more difficult to identify, especially if shadowed under calcified bone or vessels. We will now go over specific common minimally invasive pain procedures. Epidural steroid injections, or ESIs, have been described as a bread and butter of minimally invasive treatment for neck, back, and radicular extremity pain. with a wide variety of techniques and medication doses used. The goal of an ESI is to deliver steroid as a single agent or combined with a local anesthetic to the presumed source of radicular and back pain. First described in 1952, it is the most commonly performed pain procedure in the world, and over 40 placebo-controlled trials have evaluated its efficacy and cost. Currently, the pain community accepts that while ESIs for radiculopathy will result in immediate improvement in pain and function, it tends to have small, unsustained benefits and no effect on the long-term risk of surgery. Meta-analyses have concluded that there is no superior technique or steroid dose for ESIs. ESIs likely have an important role for patients with radicular pain and is likely more efficacious in combination with multimodal therapies. Patients with factors that predict poor response, as illustrated in Table 195.2, who are often prevalent in the chronic pain population, are often excluded from trials on pain techniques. Therefore, it is difficult to know the rate of ESI efficacy in the true clinical population. Since pain is a subjective experience, patient feedback is a crucial component of assessing efficacy, and there may be a placebo response or expectation bias as high as 35% with each injection. Note that since this is an invasive procedure, active anticoagulation, site infection, or injectate allergy are all contraindications for this technique. Additionally, psychopathology, high clinical disease burden, clinical comorbidities, and work-related factors have been shown to be associated with less efficacious pain control. Facet joint procedures, including intra-articular and medial branch blocks, are the second most commonly performed procedure in pain clinics. The anatomy of the cervical, thoracic, and lumbar medial branches is demonstrated in figures 195.3 and 195.4. Facet joints begin at C1 to 2 and are present down to L5 to S1 spinal levels. They are synovial joints with the capsule and synovium extensively innervated with sensory fibers. These sensory fibers express mechanoreceptors and nociceptive neurotransmitters such as substance P, and derive from the medial branch of the posterior rami of two segmental spinal nerves originating from above and below the interspace, as illustrated in figure 195.3. Physicians are recommended to incorporate facet loading maneuvers into physical examination to assess pain distribution and referral patterns, shown in figure 195.5. For diagnostic blocks, most clinicians will give the patient 2 sets of unsedated medial branch injections under fluoroscopic guidance. The patient is blinded to whether a short or long-acting local anesthetic was injected. Post-procedure, the patient is asked to complete a pain diary every hour. If the pain relief for each of the 2 blocks is concordant with the expected duration of the local anesthetic, the clinician can decide to proceed toward denervation. Various technical considerations have led to the use of radiofrequency energy as a method of choice for denervation of the medial branches. This is illustrated in Table 195.3. The same lesion generator used for intracranial functional neurosurgery is used for radiofrequency neurolysis. This increases safety by stimulating adjacent structures with a harmless electrical field prior to denervation, decreasing the potential for motor and sensory deficits. While classically described in the lumbar space, radiofrequency denervation of cervical medial branches for the treatment of head and neck pain have better evidence for efficacy and are frequently done. The medial branches of 2 segmental spinal nerves innervate each facet joint ipsilaterally, and therefore both of these 2 branches must be ablated per spinal level to denervate the joint. The sympathetic nervous system is commonly described as the fight or flight part of the autonomic nervous system. Among its multiple effects are vasoconstriction, tachycardia, decreased intestinal motility, and piloerection. Efferent fibers of the sympathetic nervous system begin in the intermedial lateral column of the spinal cord and exit along the ventral roots, from T1 to L2. These fibers then leave the ventral root as a white rami communicantes and enter the sympathetic chains, which lie on the anterolateral aspect of the vertebral bodies. These preganglionic fibers eventually synapse in one of the sympathetic ganglia. After synapsing, the postganglionic fibers then travel to their sites of action. Afferent fibers of the nervous system carry pain through two routes. Somatic pain is transmitted along the somatic nerves, while visceral pain, characterized by burning and aching from C fibers, travel through the sympathetic ganglia but do not synapse there. These fibers enter the spinal cord through the dorsal roots and have their cell bodies in the dorsal root ganglia. Due to the proximity of these anatomical pathways, sympathetic blocks will anesthetize the visceral sensory nerves as well. Previously, the diagnosis of complex regional pain syndrome type 1 required the reduction of pain and autonomic dysfunction after sympathetic blockade. While this response is no longer required for diagnosing CRPS 1 or 2, blocking sympathetic outflow with local anesthetics is still useful for predicting the effectiveness of sympathetic neurolysis. This is most commonly done for the celiac plexus and pancreatic cancer. Blockade of C fibers can often yield tremendous pain relief, even if the disorder is unrelated to the sympathetic nervous system. When properly done, sympathetic nerve blocks do not cause somatic numbness or motor blockade, unlike somatic nerve blocks. This can be a useful technique for patients who do not receive pain relief from other methods. Some patients accept significant risk for morbidity or mortality from sympathetic blockade because it is such an effective treatment of their pain, especially when they are living with a terminal illness. The vasodilation caused by a sympathetic block can also be helpful in treating vasculopathies with vasoconstriction, poor tissue perfusion, and ischemic pain. In these conditions, the sympathetic efferent fibers, rather than pain-transmitting afferent C fibers, are the target of therapy. Slow-healing wounds or diseases with vasospasm and tissue ischemia may also respond to sympathetic blockade. Extreme cases may warrant sympathetic neurolysis to give the patient pain relief and allow wound healing. Peripheral vascular surgery, or small arterial anastomoses after traumatic amputation and reimplantation, may benefit from sympathetic blockade, which prevents postoperative vasospasm and may improve surgical success. Sympathetic ganglion blocks include the sphenopalatine ganglion, stellate ganglion, thoracic ganglion, celiac ganglion, and lumbar plexus blocks, and are done under fluoroscopic or ultrasonic guidance. There has been a significant rise in the use of anesthetic injections for chronic pain since the 2000s, with some evidence that these minimally invasive procedures may reduce the need for more invasive surgery. In our current practice, such procedures may decrease opioid use. The introduction of fluoroscopy and ultrasound has improved safety and led to our ability to precisely deliver therapy to specific anatomical targets. The biopsychosocial aspect of pain is difficult to measure. Since chronic pain conditions are often attributed to more than one cause, studies assessing the efficacy of minimally invasive procedures show that it provides the highest benefit as part of a multimodal treatment that also includes musculoskeletal, psychosocial, and functional treatments. Further research and technological developments are in progress to increase the range of minimally invasive anesthetic techniques for pain management.